Welcome to this deep dive. Usually when we talk about a bodily function, we carry this expectation of simplicity.
Right, like you just do it without thinking.
Exactly. You think about breathing, for instance. Your chest rises, your chest falls.
Or a reflex, like tapping your knee with a little hammer to make your leg kick.
Yeah, we operate under the assumption that these everyday actions are just automatic, mindless processes. But then you look at the act of swallowing, and that illusion of simplicity just completely falls apart.
It really does. I mean,
Okay.
it is not a basic reflex at all.
No, it's a wildly complex, high-stakes mechanical sequence, and that is exactly what we are putting under the microscope today.
Because we perform this sequence, what, hundreds of times a day?
Mm.
And we do it without dedicating a single conscious thought to it?
Yeah, we rarely consider the absolute anatomical precision required to prevent our morning coffee or, our dinner from traveling down the wrong pipe and ending up in our lungs.
And when that precision fails, it goes dangerously wrong. Which brings us to the core of what we're looking at today.
Right. Our mission for this deep dive, we are looking at a massive stack of source material today. We've got medical science notes, clinical guidelines, historical texts, all to unpack a condition called dysphagia.
Which is the medical term for difficulty swallowing.
Yeah, and we're framing this strictly through a clinical and nursing lens for you today. We aren't just talking about a mild inconvenience at the dinner table.
No, not at all. We want to show you how healthcare professionals assess airway risk, how they prevent life-threatening complications, and how they navigate some surprisingly intense medical debates.
Okay, let's unpack this, starting with the word itself. Like, if you break it down, dysphagia comes from the Greek roots. You've got meaning difficulty or disordered,
Right.
and phagein, meaning to eat.
But we have to establish a crucial medical distinction for you right at the start here. Dysphagia is a symptom, or I guess you could call it a syndrome. It is not a standalone disease.
Oh, okay, so it's more of a warning sign.
Exactly. Clinicians view it as a giant red flag, signaling that an underlying problem has disrupted the swallowing pathway somewhere. And in the medical field, it's split into two main categories.
Which dictate the entire course of treatment, right?
Yeah, entirely. So first, you have esophageal dysphagia. This is the sensation that food is sticking or, moving too slowly lower down in the chest after it has already left the throat.
And based on the notes, that usually points to a structural issue in the esophagus itself, like a stricture, for example, where the tube physically narrows.
Right. Or a motility problem like echolalia.
Echolalia. That's essentially nerve damage, right?
Yeah.
Where the esophageal sphincter at the very bottom of the tube just refuses to relax.
Refuses to let the food pass into the stomach.
Yeah.
The food just sits there.
Wow. Okay, so that's esophageal. What's the second category?
The second category is oropharyngeal dysphagia. So this is the difficulty of initiating a swallow in the first place, or safely moving the food from the mouth into the throat.
And this specific area, this is the domain of nurses, speech-language pathologists, or SLPs and neurologists.
Yes. And we need to emphasize that oropharyngeal dysphagia carries the absolute highest risk of mortality.
Which makes sense when you look at how the medical understanding of the throat has evolved. I mean, for decades, swallowing was considered just a simple single reflex arc.
But modern clinical science completely reframed it.
Right.
It's actually an incredibly rapid four-phase sequence.
Right, you've got the oral preparatory, oral, pharyngeal, and esophageal phases.
And that sequence requires the coordinated timing of roughly 30 pairs of muscles and 6 different cranial nerves.
30 pairs of muscles just to swallow a bite of food.
Just for one swallow.
So if it's not a single reflex, what is actually happening physically between the moment a bite of food enters your mouth and the moment it hits your esophagus?
Well, the sequence starts with the oral preparatory phase. Your teeth chew the food, and your tongue mixes it with saliva to form a cohesive, wet ball.
Which clinicians call a bolus, right?
Right, a bolus. Then comes the oral phase, where the tongue actively propels that bolus toward the back of the throat.
And up to this point, it's completely voluntary, like you are actively controlling it.
Exactly. You control it. But once that bolus hits the back of the throat, it triggers the pharyngeal phase, which is entirely involuntary.
It's out of your hands at that point.
Completely out of your hands. Within about half a second, the airway must completely seal itself off to let the food pass safely over it.
And this is where the anatomy gets so fascinating. Instead of thinking about it like a simple reflex, it's more like a high-speed biological obstacle course.
A very precise obstacle course.
Yeah, where a series of trapdoors basically have to open and close in the exact right millisecond. Like, the soft palate lifts up to block the nasal cavity so food doesn't go up into your nose.
Nobody wants that.
Right. And then the epiglottis, which is this little flack of cartilage, it tips down like a lid over the airway.
And at the same time, the vocal folds inside the airway snap together like double doors.
And the entire larynx, the voice box, pulls physically up and forward to tuck itself out of the way of the falling food.
So if any one of those 30 muscles fires a fraction of a second too late, or if a cranial nerve fails to send the signal, those trapdoors just don't shut in time.
Which is terrifying. Swallowing is essentially a high-speed relay race where a dropped baton means food goes directly into your airway.
That's a great analogy. And because there are so many moving parts, dysphagia is rarely an all-or-nothing failure.
Right. It depends on exactly which runner drops the baton. Like someone could have the muscle control to swallow thin liquids perfectly, but entirely fail to move solid foods.
Or the reverse. They might handle solids just fine, but thin liquids move way too fast for their delayed trapdoors to catch.
And when those trapdoors fail, we arrive at the most feared concept in this field: aspiration.
Aspiration, yes.
And the source texts are incredibly strict about differentiating between aspiration and penetration. They are not interchangeable terms.
No, they are clinically distinct. That difference was actually formalized back in 1996 by Joanne Robbins and John Rosenbach.
Right. They created the penetration aspiration scale, or the PAS.
Exactly. The PAS is an 8-point grading system used to evaluate swallow studies. So penetration occurs when food or liquid enters the laryngeal vestibule.
Which is a very top opening of the airway, right?
Right. It enters the top opening, but the material stays above the vocal folds.
Okay, so it breaches the outer defenses, but it doesn't drop all the way down into the lungs.
Correct. But aspiration occurs when that material physically passes below the vocal folds and enters the trachea.
And at that point, it is heading straight down into the delicate lung tissue.
Yes, which is where it causes severe problems. The PAS scale allows clinicians to precisely grade how deep the material goes, and crucially, whether the patient makes any physical attempts to cough it out.
Because you can evaluate a patient who experiences frequent penetration but manages to clear it every time, never actually aspirating.
Right, and then you can evaluate a patient who aspirates on a single sip of water without any prior penetration warning signs whatsoever.
And the idea of coughing it out brings up, well, here's where it gets really interesting, because it's the most counterintuitive fact in this entire field.
Oh, absolutely.
Coughing is absolutely not a reliable indicator of aspiration.
No, it's not.
The sources show that roughly a third to over half of patients who aspirate show zero visible distress. No coughing, no sputtering.
No throat clearing, no watery eyes.
It is completely silent.
Silent aspiration. It happens because the sensory nerves in the throat and airway have been blunted, usually by a neurological event like a stroke.
So the brain simply doesn't receive the panic signal that food is falling into the lungs.
Right, so it never triggers the reflex to cough and expel it.
But wait, if a patient isn't coughing or choking at all, how on earth is a frontline nurse supposed to know they're aspirating?
It's a huge challenge.
Like, if someone sitting in a hospital bed looks completely fine while drinking a glass of water, how do you catch a silent failure?
Well, we use bedside screening tools. I mean, they are imperfect, but they are the first line of defense. Because silent aspiration exists, a nurse cannot just observe a patient eating a meal and declare their airway safe.
So what does a screening tool look like?
One of the most common is the 3-ounce water swallow test. It was developed in 1992, often called the Burke protocol.
Okay, the Burke protocol, how does it work?
The nurse asks the patient to drink about 90 milliliters of water continuously without stopping.
I mean, 90 milliliters is actually a substantial, challenging volume of liquid.
Yeah, it's meant to stress the swallowing mechanism. If the patient coughs, chokes, or develops a wet, gurgly-sounding voice within 1 minute of finishing, they fail the screen.
Right, a wet voice indicating that water is just sitting on top of their vocal cords.
Exactly. And if they fail, they are immediately flagged for a consult with a speech-language pathologist.
But here is the vital context for this test, according to the sources. It is a screen, not a diagnosis.
That is a very important distinction. A medical screen is designed to be cheap, fast, and highly sensitive in order to cast a wide net and catch potential risks.
Right, but it still relies on observing outward signs like voice changes or delayed coughing, so it will inevitably miss some silent aspirators.
Yeah, the purpose of the 3-ounce test is just to figure out who needs a deeper instrumental look. It is never used to universally clear a high-risk patient for a regular diet.
So to truly catch silent aspiration, clinicians realized they needed a way to literally see inside the throat in real time.
Which sparked a massive revolution in dysphagia care.
Yeah, it's wild to think that before the 1980s, swallowing problems in stroke or cancer patients were usually only diagnosed after the patient developed aspiration pneumonia.
It was treated as a downstream complication. You just waited for the lung infection to appear, and then you treated the lung infection.
But then a speech-language pathologist named Jerry A. Logman changed that reactive approach.
He was a true pioneer.
In 1983, she essentially founded dysphagia as a clinical subspecialty by popularizing the modified barium swallow study, or the VFSS.
Right. So in a VFSS, the patient is taken to a radiology suite, and they are fed different consistencies of food and liquid that have been coated in barium.
And barium is a contrast agent that glows dense black on an X-ray.
Exactly. So the clinician watches an X-ray video of the swallow happening live.
So you aren't guessing if the trapdoor closed. You can actually watch the black liquid slip past the epiglottis and drop straight into the trachea.
You see the whole thing.
And then a few years later, in 1988, Susan Langmore developed a rival diagnostic technique called FE.
FEES, which stands for fiber optic endoscopic evaluation of swallowing.
Right, and instead of using X-rays, she passed a tiny flexible camera through the patient's nose and positioned it to look directly down into the throat.
What's fascinating here is that decades later, there's still no single gold standard between these two tests.
Really? They're just used for different things.
Yeah, they are distinct tools that answer different clinical questions. The VFSS gives you the entire trajectory of the swallow. You can see the mouth, the throat, and the esophagus.
But it exposes the patient to radiation, right?
Right, and you have to physically transport a sick patient down to the radiology department, and it only captures a brief snapshot of a few swallows.
Whereas Langmore's FEAS avoids radiation entirely.
Exactly. A clinician can roll the camera cart right up to the patient's bedside, making it ideal for critically ill individuals in the ICU.
But FMEAS does have a mechanical catch. The sources describe a phenomenon called the whiteout.
Whiteout, yeah.
At the exact millisecond of the swallow, the muscles of the pharynx forcefully contract and squeeze inward.
And when they do that, the tissue wraps entirely around the camera lens. So the video screen goes completely white for a fraction of a second.
Ah, so you missed the actual event.
Right. The clinician can see everything pooling in the throat right before the swallow, and they can see any food left behind right after the swallow. But the exact instant of aspiration sometimes has to be logically inferred based on what is left in the airway once the muscles relax.
Okay, but FEE does offer one massive advantage over the X-ray study, and it ties into a persistent clinical debate regarding saliva.
Yes, there has long been an argument about whether difficulty managing your own naturally produced secretions, your saliva counts as true dysphagia.
Right, like if you aren't eating or drinking anything, can you still have a swallowing disorder?
The clinical consensus now is yes. Patients who cannot clear their own saliva face an incredibly high risk for aspiration pneumonia.
Because the human mouth is just full of bacteria.
Exactly. If you are constantly microaspirating bacteria-laden saliva into your lungs simply because gravity pulls it down and your trapdoors are weak, you will get sick.
And this happens completely independent of mealtimes.
Completely independent. And FETES is uniquely positioned to catch this. The camera allows the clinician to see secretions actively bubbling and pooling in the airway before the patient has even taken a bite of the test food.
Wow. Okay, so once a clinician uses these tools and formally diagnoses dysphagia, the immediate question is how to manage it. And for a very long time, the knee-jerk reaction across hospitals was to just thicken the patient's liquids.
Right, and the mechanical logic behind thickening liquids makes intuitive sense. If a patient's airway is closing too slowly, you want to slow down the speed of the liquid dropping toward that airway.
So you make it thicker.
Right. Liquids thickened to the consistency of nectar, honey, or pudding move much slower than regular water.
Which theoretically buys the compromised trapdoors more time to close and protect the lungs.
That concept became so entrenched that the clinical community codified it into the National Dysphagia Diet back in 2002.
But the sources highlight a harsh clinical reality here. Thickened liquids taste terrible.
They are notoriously unpalatable. The texture is awful, and patients simply refuse to drink them.
And when patients refuse to drink, they become severely dehydrated. I mean, if we mandate a diet that directly causes systemic dehydration or leads to severe urinary tract infections because the kidneys just don't have enough water, aren't we just swapping one life-threatening complication for another entirely different set of complications?
That is exactly what started happening. The evidence base proving that thickened liquids consistently reduce pneumonia rates turned out to be much weaker than daily hospital practice implied.
Wow.
So this tension led to a significant shift in intervention strategies, most notably the Fraser-free water protocol, which originated in the 1980s.
Okay, the Fraser protocol. This allows patients to drink unthickened regular water even if they are otherwise prescribed a thickened liquid diet.
Right.
But giving thin water to a known aspirator sounds completely contradictory to everything we just covered about slowing down the liquid.
It sounds wild, but the physiological theory behind the Fraser protocol is actually brilliant.
Yeah.
Pure, clean water is relatively benign if it enters the lungs in small amounts.
Wait, really?
Yes. The lungs can absorb pure H2O into the bloodstream without much issue. Pneumonia isn't caused by the water itself, it's caused by the bacteria carried along with the aspirated material.
Oh, that makes sense.
Right. So if a patient is given rigorous oral care to remove bacteria from their teeth and tongue, and then they're permitted supervised sips of plain water, the aspiration risk is vastly less dangerous than aspirating a food particle or contaminated saliva.
That is fascinating. But moving away from the thickened liquid dogma also exposed how chaotic hospital diets used to be. Like, a liquid labeled nectar thick in a bustling city hospital might have a completely different viscosity than a nectar thick liquid at a suburban nursing home.
And inconsistency in medical terminology is a massive safety hazard. If a patient is transferred between facilities and given the wrong liquid consistency because of a translation error, the resulting aspiration could be fatal.
And that systemic danger is why Julie Cicero helped establish IDDSI in 2013.
Yes, the International Dysphagia Diet Standardization Initiative.
Right. They basically threw out all the old subjective labels and created a unified global 8-level framework.
Ranging from level 0, which is thin water, all the way up to level 7, which is regular unmodified food.
And every level has specific syringe flow tests to objectively measure thickness. It prevents those deadly mix-ups across care transitions.
Standardizing the diet is a vital step, definitely, but we also need to examine who these safety protocols are actually protecting, because there is a pervasive public misconception that swallowing disorders solely afflict the elderly.
Yeah, that is a huge myth. The demographics in the literature are surprisingly broad. Dysphagia affects premature babies in the neonatal intensive care unit whose neurological systems haven't fully developed.
It affects young adults who have suffered traumatic brain injuries in car accidents.
It's a major factor for people of any age living with Parkinson's disease, ALS, or multiple sclerosis.
And we have to mention the COVID-19 pandemic completely dismantled the elderly-only assumption.
Oh, how so?
Intensive care units saw a massive influx of previously healthy patients requiring prolonged intubation and proning, which is lying patients flat on their stomachs to improve oxygenation.
Right.
Historically, many clinicians assumed that once a breathing tube was removed, a patient's swallowing function would naturally bounce back within a few hours.
Yeah, why doesn't it just bounce back? Like, if the tube is out, shouldn't the throat work again?
Think about it mechanically. An endotracheal tube is a piece of plastic wedged directly between the vocal folds. If it stays there for weeks, it physically props the airway open.
Oh, wow.
The delicate muscles of the pharynx undergo severe atrophy from disuse, much like a leg muscle shrinking while inside a cast.
That makes perfect sense.
Plus, the trauma of the tube rubbing against the tissue causes inflammation, and proning causes massive fluid swelling in the face and neck. We now know that post-extubation dysphagia is incredibly common and persistent. Absolutely. Clinicians can no longer pull a breathing tube and immediately hand a recovering patient a glass of ice water. A rigorous swallow screen is mandatory now.
Okay, so as we look at who is at risk, the sources are also very careful to differentiate true dysphagia from a few related conditions that often get lumped together.
That's right. Dysphagia is a mechanical failure of the swallowing process. It is not odonophagia.
Which simply means painful swallowing.
Right. Odonophagia is strictly about the sensation of pain, often caused by severe acid reflux burning the esophageal lining, or maybe inflammation from radiation therapy.
But a patient can have painful swallowing while their mechanical trapdoors work perfectly, or they can occur together.
Exactly. They aren't the same thing.
The sources also detail the globus sensation.
Yes. The globus sensation is the persistent feeling of a lump in the throat. It closely mimics the feeling of food being stuck.
But if you put these patients under a VFSS X-ray, there is no physical obstruction and no mechanical failure, right?
The bolus clears perfectly. Globus is very frequently linked to severe anxiety or stress, which causes the cricopharyngeal muscle at the top of the esophagus to involuntarily spasm or hold tension.
So it creates a very real physical sensation of a lump despite the tube being totally clear.
Yes, exactly. And finally, there is presbyphagia.
Presbyphagia. Wait, what is that one?
This one is crucial for understanding the aging population. It is the normal, expected age-related decline in swallowing function.
Oh, so just because you're getting older.
Right. As human beings age, we lose muscle mass. Our reflexes slow down. The tissues in the throat lose elasticity.
So it's not a disorder then?
No, presbyphagia is not a clinical disorder. It is just aging. However, it significantly lowers a person's physiological margin of safety.
Meaning an older adult might swallow adequately on a normal day, but they are much more vulnerable to developing true life-threatening dysphagia if they suffer even a minor secondary insult.
Like a small stroke, a bad urinary tract infection, or even generalized weakness from a cold.
That diminished margin of safety really highlights how we need to view swallow studies in general.
Yes. If we connect this to the bigger picture, a diagnostic test, whether it's the X-ray or the camera, is just a snapshot of a single moment in time.
Right. Swallowing function fluctuates wildly. It changes based on a patient's daily fatigue level, the natural progression of a neurological disease, their physical recovery from a stroke,
Or even the side effects of medications they took that morning.
So if a patient is given a strict diet restriction on a Tuesday, it is not necessarily a permanent life sentence.
Not at all. Their ability to swallow has to be continually reevaluated as their overall health shifts.
So what does this all mean? We have explored the intricate mechanical trapdoors of the throat, the silent threat of aspiration, and the fierce clinical debates over thickened liquids.
It's a lot to process.
It is. Why does the intricate science of dysphagia matter to you? It matters because it sits at the intersection of incredibly high everyday stakes. A simple bedside swallow screening by a nurse is one of the highest yield, lowest cost interventions in all of acute care.
It actively prevents aspiration pneumonia, which remains a leading cause of death and hospital readmission worldwide. It is the definition of frontline preventative medicine.
But beyond the mechanics and the pneumonia statistics, dysphagia carries a profound human weight.
It really does. The act of eating is deeply tied to human culture, psychological comfort, and daily autonomy. When a clinician has to write an order for NPO status nil per os, meaning absolutely nothing by mouth, it is a devastating loss for the patient.
And clinicians often have to guide families through the decision of placing a PEG tube.
Right, that is a percutaneous endoscopic gastrostomy, where a surgical feeding tube is placed directly through the abdominal wall into the stomach, bypassing the throat entirely.
Alternatively, families might choose comfort feeding for end-stage dementia patients, where the medical team accepts the high risk of aspiration pneumonia in order to preserve the patient's remaining quality of life.
And those decisions represent some of the most emotionally weighty conversations in modern healthcare.
It is absolutely not just a plumbing problem. It is a fundamental quality of life issue that alters how people interact with the world. I want to leave you with a final thought to ponder. Something derived directly from the source material's notes on saliva management and strict dietary orders.
It's a profound point.
Think about this. If a patient is placed on strict NPO status, meaning they're permitted absolutely zero food or drink by mouth in an effort to prevent aspiration, they are still generating and swallowing their own saliva every single minute of the day.
Right.
If the inability to safely manage your own bacterial secretions is its own standalone risk category, does the simple biological act of existing and producing saliva mean that NPO orders are an incomplete shield? Can we ever truly eliminate the risk of aspiration just by withholding a meal?
That dynamic forces clinicians to constantly weigh the limits of medical intervention against the reality of human physiology.
Thank you for joining us as we unpack this high-stakes mechanical sequence.
Thank you for listening to this deep dive.